This is the New York State Check and Inject Epinephrine for EMTs. This video that you will be seeing has been modified slightly to reflect the new changes of where the New York State Department of Health would like to see the epinephrine being injected. Initially, the injection site was the lateral aspect of the outer thigh. The site for the check and inject epi for EMTs will be the deltoid muscle, which you will see a video on that during this presentation.
Hello, and welcome to the Check and Inject New York training program. I'm Jeremy Cushman, an EMS physician and medical director for the Monroe-Livingston region. Today, I'll be sharing with you this important New York State demonstration program for BLS provider administration of the syringe epinephrine kit. On behalf of the Check and Inject New York project team, I hope you find this training valuable, and I thank you in advance for your participation in this important demonstration project. Check and Inject New York was developed and is being implemented as a New York State demonstration project as approved by the CMAQ and the State Health Commissioner. Any EMS agency which currently utilizes epinephrine autoinjectors in their treatment protocols is eligible to enroll in the Check and Inject demonstration project, which will run for a period of approximately 18 months. The project data will then be reviewed by the CMAQ, who will make their recommendation to the Commissioner of Health. Importantly, syringe epinephrine kits are not currently approved for use by agencies not enrolled in the Check and Inject demonstration project. Through this video and the skills-based training that follows, I will share the rationale for the Check and Inject New York program, review the triggers, signs, symptoms, and treatment of anaphylaxis, including how to differentiate a localized allergic reaction from life-threatening anaphylaxis. Then we'll spend some time demonstrating intramuscular medication administration and how to assure we are safely drawing up, administering, and disposing of an intramuscular injection. BLS providers have successfully shown through other demonstration programs, such as naloxone and CPAP administration, that they are capable of providing what were previously considered advanced skills. The injection of intramuscular epinephrine is another such skill that with the proper training, BLS providers can safely administer. Although autoinjectors are one way to administer life-saving epinephrine to a patient with anaphylaxis, it is not the only way. The cost and potential for self-injury are not insignificant, and moving to a different delivery mechanism has the potential to save our EMS systems millions of dollars while maintaining the important ability to treat patients with anaphylaxis. New York is not the first to explore this delivery route amongst its EMTs. King County, Washington began their program in 2014 and have demonstrated through hundreds of applications that BLS providers were able to successfully administer epinephrine to a patient experiencing anaphylaxis. In some instances, treatment may have been aided by the use of the syringe epinephrine kit versus conventional epinephrine autoinjectors. All these administrations were done safely and without injury to providers. Since that time, several other regions and states across the country have also successfully implemented similar programs. The Check and Inject program is modeled after these successful programs. Let's start with a review of anaphylaxis. Anaphylaxis is a systemic reaction, meaning that it affects the entire body. It is typically characterized by shock and/or respiratory symptoms that are characterized by a rapid onset. It is not necessary for all of the individual components to be present for a patient to be in anaphylaxis. Important to remember is that a patient experiencing anaphylaxis who is left untreated will die. Also important is that anaphylaxis is not the same as an allergic reaction or seasonal allergies that many of us may have experienced. These may include an insect bite that itches, a runny nose, sneezing, or watery eyes. Although these are allergies, they do not have the rapid onset of systemic effects that are found with anaphylaxis. So again, anaphylaxis is a sudden, systemic, and life-threatening condition. Although anaphylaxis is not the same as an allergic reaction, they are similar and that both result from an exposure to an allergen, an important point to consider when you are making your treatment decision. An anaphylactic reaction is triggered by an allergen. An allergen can be just about any substance that a patient may come in contact with. We know that some substances are more likely to cause an anaphylactic reaction and may also cause the reaction to be more severe or progress quicker. Some of these allergens, and therefore causes of anaphylaxis, include certain foods such as nuts or shellfish, sensitivity to bees, wasps, and other insects, medications such as antibiotics, or even plants or latex. The life-saving treatment of anaphylaxis is very simple. Patients need an intramuscular injection of epinephrine to improve respiratory distress, reduce any airway swelling, and counteract hypotension. Additional interventions, such as antihistamines, nebulizers, and steroids, may be given by advanced life support personnel, but nothing is more important than epinephrine. Let's review a few different presentations that will lead a provider to administer an intramuscular injection of epinephrine. In the first presentation, our patient is exposed to a likely or common allergen, but has not had a prior anaphylactic reaction. When that occurs, and the patient rapidly experiences signs or symptoms from any two of the categories listed, the provider should administer an injection of intramuscular epinephrine. So let's say we have a child that is eating peanut butter for the first time and rapidly develops hives and difficulty breathing. This person would meet the definition of anaphylaxis as they have a potential exposure to an allergen and both skin and respiratory symptoms. Alternatively, let's say a gentleman is stung by a bee, rapidly develops difficulty breathing, and then passes out. You note him to have a very low blood pressure. This person would also meet the definition of anaphylaxis, as he has been exposed to a likely or potential allergen and has both respiratory symptoms and a decreased blood pressure. Both of these patients have anaphylaxis and would be best treated with an intramuscular injection of epinephrine. In the second presentation, our patient has had a previous anaphylactic reaction and may even have an epinephrine autoinjector prescribed to them as a result. Following the exposure, the provider should administer an injection of intramuscular epinephrine when signs or symptoms from any one category is present. So, for example, a woman with a known shellfish allergy is exposed to crab meat and has immediate shortness of breath. This person would also meet the definition of anaphylaxis, as she is exposed to a known allergen and has respiratory symptoms. These combinations of exposures, signs, and symptoms can help identify patients in anaphylaxis. However, anaphylaxis is not limited to just these specific algorithms. Each provider needs to assess each patient on a case-by-case basis to determine the presence of anaphylaxis and the need for an intramuscular injection of epinephrine. This chart is a convenient reference for many of the most common presentations, but all care decisions must ultimately be made within the scope of local or regional protocols or with direction from a medical control physician. Speaking of protocols, the Check and Inject demonstration program does not supersede your existing protocols for care of patients with anaphylaxis. For example, here's the protocol for allergic reaction and anaphylaxis taken from the 2014 Collaborative New York Protocols. Taking a closer look at the EMT section of the protocol, you will notice that the provider is directed to administer epinephrine in the setting of anaphylaxis after addressing airway management and oxygen therapy. The indications and ability to administer and the requirements to contact medical control, if any, remain the same during your participation in the Check and Inject program, and you are directed to your local protocols which statewide recognize the life-saving benefits of early epinephrine administration. So now that we have reviewed the indications and importance of epinephrine in the anaphylactic patient, let's review a few cases. Our first case involves a 15-year-old girl that was stung by something while she was at summer camp. Several minutes later, her eye began to swell and she walked to the nurse's office. Her exam is as depicted on the slide. An ambulance was called for the patient to be evaluated. The patient walked to the ambulance where EMTs transported her to a local community hospital after speaking with parents via phone. En route, the crew monitored her for any airway swelling, difficulty breathing, or changes in mental status. She was delivered to the hospital emergency department without progression of her symptoms. In this case, our patient appropriately did not receive epinephrine, for although she was exposed to a potential allergen, she exhibited only skin findings and did not have respiratory symptoms or hypotension. Importantly, however, the EMT monitored the patient closely for any change in her condition, as sudden hypotension or respiratory symptoms would be an indication for epinephrine. This next case involves an elderly woman who was out to dinner with family for a birthday celebration. Shortly after arriving home, she noticed this rash across her back, chest, and face while getting ready for bed. As she has a known allergy to shellfish, she is typically very careful about what she eats, but believes she may have been exposed during dinner unknowingly. When she began to have difficulty breathing, she immediately called 911. When EMTs arrived, this patient was recognized to be suffering from an anaphylactic reaction after only a brief assessment and history of events. The patient has a rash and respiratory symptoms in the setting of a likely allergen exposure. The EMTs immediately administered epinephrine in her left thigh, as there are no contraindications to epinephrine in the setting of anaphylaxis. The patient was placed on oxygen, moved to the ambulance, and transport to the emergency department was begun. En route, the patient reported resolution of her difficulty breathing, and reassessment revealed easy ventilations and clear lung sounds. Advanced life support was met en route, and the patient was closely monitored for reoccurrence of symptoms for the remainder of the transport. In this case, our EMTs appropriately administered epinephrine to our patient with a known allergy history and respiratory symptoms. Our final case involves a 3-year-old child that was at a family picnic with friends and relatives. The patient approaches her mother carrying a large bowl of strawberries. Her face appears covered in strawberries, and she is complaining that she doesn't feel well. The child crawls up into her mother's lap, resting her head against her, and appears to fall asleep. 10 to 15 minutes pass when a relative points out that the patient looks pale and asks about the rash around her mouth. As the mother tries to wake the patient, she finds that she is unable to do so, and EMS is requested. EMTs arrive and recognize that despite the lack of more classic symptoms, this patient was experiencing an anaphylactic reaction. She has an exposure to a potential allergen, has signs of shock including delayed capillary refill and altered mental status, as well as poor respirations. The EMTs assist her ventilations, administer epinephrine, and begin transport as they should not delay on scene waiting for advanced life support. Fortunately, the crew is able to intercept with ALS en route to the hospital. The patient became increasingly more alert and began crying forcefully at the time of their intercept, allowing the EMTs to discontinue the assisted ventilations. This is certainly not a classic presentation of anaphylaxis, but our patient had a possible exposure, and important to remember is that not all anaphylactic reactions have hives and swelling. These more subtle symptoms should not delay the administration of epinephrine, as it is life-saving in this little girl's case. Now that we have reviewed the signs and symptoms of anaphylaxis, and we know who we should be giving epinephrine to, let's review how to give them that life-saving epinephrine. Anytime a medication is given to a patient, it is important that several factors are verified before the actual medication administration occurs. Every time we must ensure that we have identified a need for the drug's administration, selected a proper route of administration, and verified both our drug and dosage before any administration occurs. We must then properly administer and document that administration as our care continues and is eventually transferred to another provider. EMTs are already familiar with many of these steps, as in many regions you routinely administer drugs such as albuterol, aspirin, nitroglycerin, and others as allowed. This is the reference card contained in each check and inject kit. Let's take a minute to review each section as it pertains to the administration of intramuscular epinephrine for anaphylaxis. This reference card is intended to be used as an aid while administering epinephrine in the check and inject program. So our first step is to verify the need for epinephrine. As we discussed earlier, only a patient in anaphylaxis is going to receive an intramuscular injection of epinephrine. That determination comes from an exposure to an allergen, associated signs and symptoms of anaphylaxis, and guidance from your local or regional protocol. We discussed some common signs and symptoms earlier, and those are referenced here on the check and inject insert. This may serve as a useful reminder after you have opened the kit for administration. Here we can see the check and inject kit that you will be using as part of this demonstration program. You can see that the syringe epinephrine kit is sealed, the label is intact, and the expiration date has not passed. Opening the kit, we can inspect the individual components which are also listed on the cover. The kit includes 1 vial of epinephrine, 1 custom syringe, 1 safety needle, 2 alcohol wipes, 1 adhesive bandage, and 1 check and inject paper insert that I demonstrated earlier. The third step is to verify the drug. When a drug is administered through the intramuscular route, the provider needs to ensure that they are administering the correct drug, the drug is not past its expiration date, and that the contents of the vial are clear and free of floating objects. Although the check and inject kit was sealed, check to make sure the vial of epinephrine is not expired and the fluid remains clear and free of debris. Whenever you administer a drug, you should have an understanding of how that drug is intended to work, what side effects can be expected, and what complications may arise and how those should be managed. As epinephrine is already being administered by BLS providers, we will limit our time here to a quick review. You may recall epinephrine is a manufactured form of adrenaline, which is naturally occurring in the body. Epinephrine works to stimulate the sympathetic nervous system of our body. In other words, it turns on our fight or flight response. The onset of a drug is how long it takes for our body to respond. This time can vary greatly depending on the drug itself and the route by which it was administered to a patient. Some drugs may work in seconds, while others could take a half hour or more. Epinephrine, administered through the intramuscular route, would typically begin working in as few as 90 seconds if it were administered to a healthy patient. Since we are administering epinephrine to a patient in distress, it may take as long as 3 to 5 minutes before the epinephrine begins to work. It is also possible that a single dose is not sufficient to treat a patient. By understanding the onset of the drug, we can also understand why we should be considering our second dose of epinephrine in as little as 5 minutes after the initial dose was administered. Once the provider begins to see improvement in the patient, the duration, or how long the drug will last, can be 1 to 4 hours. It can also be much shorter than that, and frequent reassessment is essential. It is important to recognize that there are no contraindications to the administration of intramuscular epinephrine in a patient experiencing anaphylaxis. When you practice this skill later on, you should have a copy of your local or regional protocol to reference. It is possible that protocol may restrict your ability to administer epinephrine in some situations. If that is the case, you must follow your local protocols, despite the information that was presented here today. Side effects of epinephrine are related to its effect on our fight or flight response. We can expect someone to have received epinephrine to potentially experience palpitations, high blood pressure, feeling anxious or jittery, having tremors, or experiencing a headache. All of these are known side effects of the medication, but these side effects are outweighed by the life-saving effects of the drug. Our fourth step is to verify the dosage and draw up the appropriate dose. The Check and Inject project has made dosing simplified with the custom-designed syringe. There are only 2 markings on the syringe, an adult and a pediatric dose. The standard dose of epinephrine across most of New York State is 0.3 milliliters for adults and 0.15 milliliters for pediatrics. The difference between adult and pediatric patients is made based on the weight of the patient and not chronological age. Any patient weighing equal to or more than 30 kilograms or 66 pounds will receive an adult dose of intramuscular epinephrine. There are some areas of New York State where the protocol may indicate a different dosage. Those protocols are ALS level protocols and are not applicable to the EMT or the check and inject program. The Syringe Epinephrine Kit project is intended only to evaluate the replacement of epinephrine autoinjectors. The 0.3 milliliter and 0.15 milliliter doses correlate to that found in the adult and pediatric epinephrine autoinjectors that are commercially available. During the training process, we will be utilizing a training vial of epinephrine, which should be clearly labeled. The vial differs slightly in appearance, and the contents are water, but the vial is otherwise identical to the actual epinephrine found in the syringe epinephrine kits. Providers should verify that they are administering the correct drug, the drug has not passed its expiration date, and that the contents are clear and free of debris. Here you can see the custom-designed syringe which we will use for all intramuscular epinephrine administrations. The top image highlights the markings for an adult dose, while the image on the bottom highlights the marking for a pediatric dose. Now let's take a minute to observe a short video of attaching the needle to the syringe and drawing up the medication. You will practice this process during the skills session of this training.
In order to draw up the epinephrine, we must first remove both the syringe and needle from their packaging. The syringe and needle are then assembled by simply pressing them together. The EpiSafe syringe has only two markings on its barrel. The first at 0.15 milliliters for pediatric patients, and the second at 0.3 milliliters for adult patients. At this time, we want to remove the safety cover from the needle, as well as the cap from the vial of epinephrine. Inverting the vial, we want to inject the needle through the stopper so that only the tip of the needle is visible inside the vial. Depress the plunger and expel any air into the vial. Once completed, begin to slowly withdraw your plunger, allowing drug to fill your syringe. Once your syringe has filled with epinephrine, remove the needle from the vial and hold the syringe with the needle pointed upward. Gently tap the side of the syringe, allowing any trapped air to make its way to the top. Once again, gently depress the plunger until the stopper returns to the desired dose. This will expel any excess drug or trapped air and leave you with a syringe that is ready to administer.
Once the drug is drawn into the syringe, our fifth step is to inject the medication. The injection process is a skill that you will have an opportunity to practice. It is important to administer the injection correctly to ensure your patient receives the necessary medication, but also to understand safe handling practices of the needle to ensure the safety of you and your colleagues. To inject, you want to align the syringe and the needle above the injection site at a 90-degree angle to the skin. It is important that the needle reaches through the subcutaneous tissues, as it may take twice as long for epinephrine to have its life-saving effect if not injected directly into the muscle. In these photos, you can see the needle is being held at 90 degrees to the surface being injected. The plunger can then be pushed completely to administer the entire dose. Once the injection is complete and the needle removed, the safety mechanism is engaged. The entire syringe should be properly disposed of in a sharps container. It is never acceptable to leave the needle unattended or in any location outside of an approved sharps container after administration. Let's take another minute to observe the intramuscular injection procedure that you will be practicing during the skills session.
This site has been exposed and cleaned with the alcohol preps provided. To administer the injection, the needle should be held 90 degrees to the surface of the skin and inserted with a quick, dart-like action. Now slowly depress the plunger to administer the epinephrine. Once the needle has been removed, immediately engage the needle's safety feature with a one-handed technique. Massage the injection site for up to 30 seconds before covering with an adhesive bandage.
Once the epinephrine has been administered and the needle has been safely disposed of, reassessment of the patient should begin. Ideally, we want and expect our patient's signs and symptoms to improve. You should be observing for signs of improvement or side effects, begin transport, and recall that if the patient has not had any significant improvement after 5 or more minutes, that your protocol may allow a second dose of epinephrine. Whenever possible, please update your responding advanced life support agency, and if you are a transporting unit, do not remain on scene waiting for ALS. After your transfer of care, you will document and perform a debriefing process regarding your use of the check and inject kit. There are several reasons we need good, accurate documentation. Remember that good documentation includes a thorough assessment both prior to and following medication administration. That documentation should include the patient's condition and their response, as well as any side effects to treatment. Generally, you should be assessing and documenting that assessment every 5 minutes, if not even more frequently for the patient in anaphylaxis. Following the appropriate transfer of patient care, it is required that the provider calls the on-call physician for the check and inject program to report the use and complete the debriefing process. The sooner that phone call can be made, the greater the opportunities for your learning and our opportunity to improve this program. A debrief with the on-call physician is required after the use of a check and inject kit, and once complete, will trigger a replacement kit to be shipped to your agency. Dial 844 EPI call, and your call will be routed to an EMS physician who will have a few questions for you. If the physician does not immediately answer, please leave a message and they will get back to you within 30 minutes to discuss the call with you. Again, this call should be made after you transfer patient care to the emergency department or other responder for transport. This number is only for physician debriefing. Administrative concerns or questions should be routed through your agency's check and inject coordinator. Now that we have discussed all the individual parts of the program, we are going to watch an example of how the entire process would occur during a typical EMS response. Pay particular attention to the individual components and how they incorporate those into the treatment of the anaphylactic patient.
911 Center, what's the address of the emergency?
280 Calkins Road,
What city or town is that in?
Henrietta.
Okay, tell me exactly what happened.
I was landscaping and was stung by a bee.
How old are you?
33?
Have you ever had a severe allergic reaction before?
Yes.
Do you have any special injections or other medications to treat this type of situation?
I have an EPI auto-injector, but I don't have it with me.
I'm sending the ambulance to help you now. Stay on the line and I'll tell you exactly what to do next.
Thank you. The EMTs are here now.
Okay, good luck to you.
Thank you.
Hi, sir. I'm Brian. This is Alex. What's your name? Ben? What happened? Stung by a bee? Are you allergic to bees? Do you have epinephrine? Do you take it? But you don't have it. Okay. All right. Let's get you checked out. Open up your mouth for me. Stick your tongue out. Yeah, it's red. Does it feel swelled? Okay. Listen to your lungs here. Deep breath. Yeah, you got a lot of wheezing.
90 on 60 for the pressure.
Oh, okay, I'm gonna get his pulse. He's wheezing. He's got a swelled up tongue and airway. Oxygen, yeah. Oh. We're gonna get some oxygen to help you breathe, all right? It's coming. Oh. Heart rate of 120. I'll tell you what, why don't you give me that? Find out where our ALS is, please.
ALS is 10 minutes out.
10 minutes away. All right, here's an oxygen mask. You have an EpiPen, but you don't have it with you, right? Okay, breathe on that. He's got anaphylaxis. Wheezing, trouble breathing, swelled airway, and hives.
Yep.
I think we get the syringe epinephrine kit. Let's do that, and then we'll load him up and meet ALS on the way.
I'm just going to grab the checklist out.
Grab the checklist.
There's the syringe-epi kit.
Okay.
Alright, so we've established the need. We established that he is in anaphylaxis.
Right.
We're going to prep the site now.
Okay, I'm gonna put it in your leg, all right? I'll cut your jeans away. I'll cut it right on the seam. Anything in your pocket there?
So once we've exposed the site there, we're going to clean it with alcohol.
Prep with alcohol. All right.
Alright, and now we're going to move on to verifying the drug. We're going to be
Okay.
using 1 to 1,000 epinephrine.
1 to 1,000.
Verifying the expiration date.
April of
And
2016.
that the contents are clear.
Clear, unbroken seal.
In order to draw up the epinephrine, we must first remove both the syringe and needle from their packaging. The syringe and needle are then assembled by simply pressing them together. The EpiSafe syringe has only 2 markings on its barrel. The first at 0.15 milliliters for pediatric patients, and the second at 0.3 milliliters for adult patients. At this time, we want to remove the safety cover from the needle, as well as the cap from the vial of epinephrine. Inverting the vial, we want to inject the needle through the stopper so that only the tip of the needle is visible inside the vial. Depress the plunger and expel any air into the vial. Once completed, begin to slowly withdraw your plunger, allowing drug to fill your syringe. Once your syringe has filled with epinephrine, remove the needle from the vial and hold the syringe with the needle pointed upward. Gently tap the side of the syringe, allowing any trapped air to make its way to the top. Once again, gently depress the plunger until the stopper returns to the desired dose. This will expel any excess drug or trapped air and leave you with a syringe that is ready to administer.
Alright, we have an adult here, so we're going to draw up the appropriate adult dose of 0.3 cc's.
Okay. I'll go right to the line that says A.
Very good.
All right, I'm at the A. It stopped.
This site has been exposed and cleaned with the alcohol preps provided. To administer the injection, the needle should be held 90 degrees to the surface of the skin and inserted with a quick, dart-like action. Now slowly depress the plunger to administer the epinephrine. Once the needle has been removed, immediately engage the needle's safety feature with a one-handed technique. Massage the injection site for up to 30 seconds before covering with an adhesive bandage.
We're going to administer the dose by pushing the plunger down,
All right, we're going to give you the epinephrine, sir.
and then we're going to remove the needle,
Yep.
engage the safety cap,
Okay.
massage the site for 30 seconds, and then place a bandage.
Can you open this up?
I certainly can, sir.
And then why don't you get the ambulance gurney, and we'll get him in the ambulance and get going to meet advanced life support, okay?
Sounds like a plan. Alright.
All right, you got the epinephrine, just like your EpiPen, okay?
Stretcher.
We're going to put you on our ambulance gurney, get you nice and comfortable, and take you to the hospital real safe, okay? Let me know if you start feeling any better, but just keep breathing on that oxygen for now. Have you been stung by bees before? Yeah? Is it usually this bad? All right, that should be good. We'll engage this Band-Aid here. Nice. All right, little bump, Ben. All right, how you feeling? Any better?
Good, just so shaky.
A little shaky? All right. Yeah, as you may know, that medicine will do that to you.
Yeah.
All right. We'll get you in the ambulance and get you out to the hospital real safe. Ready, set, lift. Thanks. We'll get a blood pressure on you and get you reevaluated here.
We hope that scenario was helpful in pulling this program together for you. Through this presentation, we have discussed the rationale for the Check and Inject program. We reviewed some of the triggers, signs, symptoms, and treatment of anaphylaxis, including how to differentiate a localized allergic reaction from life-threatening anaphylaxis. We have discussed that BLS providers are capable of safely providing the injection of intramuscular epinephrine. And in the skills session to follow, you will practice and then demonstrate the safe administration of intramuscular epinephrine injections under the supervision of an instructor. Keep in mind, during the practice injections, no providers or instructors are to be administered an intramuscular injection. We hope you have found this training useful to reinforce the recognition and treatment of anaphylaxis, as well as the steps necessary to safely administer intramuscular epinephrine as a basic life support provider. Our thanks to King County, Washington for so willingly sharing their program's experiences, and to our partners at Henriette Ambulance, Monroe Ambulance, and the New York State Department of Public Health, Bureau of EMS and Trauma for making this demonstration project a reality. This program was developed and produced by the University of Rochester Division of Prehospital Medicine, and we thank the entire project team, as well as your agency's Check and Inject coordinator, and you for your participation.
Before we move on to the epinephrine intramuscular injection demonstration video for the deltoid muscle, you should go over this skill sheet with your instructor and make sure that you're covering all this information. Everything must be completed that is on this skill sheet, and all students from the beginning of the skill to the end of the skill must make sure that they wear gloves. They must make sure that they draw up the proper amount of medication, and they must make sure that when they administer the medication, they do it safely to the correct patient, and then once the medication has been administered, they make sure that the needle is withdrawn and safety cover is engaged and it is put into a sharps container. So take a couple of minutes just to review this information here before we move on to the demonstration video. In this next video presentation, you will see the landmark procedures for the IM injection in a deltoid muscle. Some of the materials they used are a little bit different than what you've been taught, but the process is the same.
Hello and welcome to today's presentation on the proper technique for an IM injection. As far as any procedure is concerned, it's always important to make sure you have your supplies first. So those supplies include hand sanitizer, gloves, your injection syringe, your medication, a Band-Aid, alcohol swab, and something to wipe up any blood if necessary. So two important details of identification are your patient and your medication. First, make sure it's the right patient through two identifiers. That would be name, medical record number, or date of birth. Make sure they're not allergic to any medications or injections. And also with your medication, make sure it's the proper dosage, the right one, and that the expiration date is valid. So get your supplies ready for drawing up the solution. Wash your hands before any procedure. And we're going to glove up. And then we're ready to go. All right, so initially you're going to make sure that your needle and syringe is functioning properly. So uncap, aspirate a little bit up to a half cc. And then for your medication, just simply pop the top. And then for multi-use vials like this, you always want to cleanse with a alcohol swab. And it's just a matter of inserting the needle into the bottle, aspirating, and drawing up your half cc or whatever it is that the amount that you need to inject. For the actual injection, you need to find the landmarks, and in the deltoid, you want to find palpate for the acromion process and go about 2 finger breadths down in the mid-axillary line, and that's a good place for the injection to go. So once you have your injection site, you want to clean it off with an alcohol swab. Let it air dry. When you're doing the injection, the needle should be bevel up. And when you're ready to inject, you want to put some tension on the fascia so that it doesn't move anywhere. And in a quick fluid motion, go straight into the muscle. Stabilize the needle with the other hand. Aspirate to make sure you're not in any vein or vessel. And then when you've done that, you can just simply inject and remove. And if you have any bleeding, simply wipe it up with a gauze pad and apply your Band-Aid. Whenever possible, it's important not to try to recap needles, so simply just dispose of it in a sharps container. That concludes this video tutorial on IM injections. Thanks for watching, and remember, practice makes perfect.